Good morning, ladies and gentlemen. My name is Dr. Andrew Gallarde, and I'm very excited to be talking to you all today about our research investigation into the use of ambulatory blood pressure by USAFP members. And we have no financial disclosures to make. This clinical investigation looks at the diagnosis of an extremely important primary care topic, hypertension. Hypertension is one of the leading reasons why patients are seen by primary care clinicians across the world, and it affects 1/3 of US adults. Often called the silent killer, hypertension is a risk factor for cerebrovascular, cardiovascular, and renal disease. This just highlights the importance of an accurate diagnosis of this condition. A set of hypertension clinical guidelines were published in the Annals of Internal Medicine in 2015. Revealed that office-based blood pressures is frequently, consistently, both unreliable and a poor prognosticator. There was significant discordance between the office-based blood pressures and the 24-hour blood pressure measurements. And it found that elevated ambulatory blood pressure was consistently and significantly associated with an increased risk of cardiovascular events, and this was independent of office-based blood pressures. The office blood pressure was also lacking because of the existence of this condition, white coat hypertension, which is elevated office blood pressures with normal daytime blood pressures otherwise. The CDC estimates that white coat hypertension actually has a 30% prevalence. Additionally, there's also a 13% prevalence of masked hypertension, which is when an individual has elevated blood pressures at home, but normal blood pressures in the office. And while not endorsed by the AAFP, the ACC-AHA guidelines defined hypertension as blood pressure greater than 130/80, further highlighting the importance of an accurate measurement to limit overdiagnosis. Additionally, the USPSTF has an in-progress Grade A recommendation for obtaining blood pressure measurements outside of the clinical setting in order to confirm hypertension diagnosis before starting treatment. So what did we hope to accomplish with our study? Well, we wanted to identify the diagnostic practices of military family physicians for these conditions I just talked about. We also wanted to assess the knowledge of the hypertension guidelines, as well as the access to 24-hour ambulatory blood pressure monitoring, and the perception of barriers to the implementation of this 24-hour blood pressure service. So the study was a cross-sectional survey as part of the IRB-approved Omnibus survey, which was conducted by the Clinical Investigations Committee of the USAFP. And due to the COVID-19 pandemic, rather than have conference attendees participate, the survey was sent out to all registered members. So of the 2,559 successfully sent emails, 284 people responded for an 11.1% response rate. The data was analyzed using descriptive statistics of selected survey answers and chi-squared bivariate analysis, comparing demographic groups. Here is our demographic information and is available for those interested, but notably the gender and time since graduation of our respondents were reflective of the overall AAFP demographics. Alright, so now I'm going to highlight our most interesting results. Our question 1 asked what the preferred recommendation was for confirming the diagnosis of hypertension. And to this, a correct response was any response that included an ambulatory method, home blood pressure logs, or 24-hour ambulatory blood pressure. You can see that 36.6% of respondents included an ambulatory method. So question 2 asked the diagnostic practices for white coat hypertension. Once again, the highlighted responses are those that have an ambulatory method, and you can see that only 56.4% did so. Question 3 asks how respondents have diagnosed hypertension most often. The highlight area shows that 27.8% relied on office-based blood pressures to make that diagnosis. Question 4 asks the frequency of home blood pressure logs to diagnose hypertension. And you can see from the highlighted area that a minority of those who responded use home blood pressure logs more than 50% of the time. And then question 5 asks the same question but for 24-hour ABPM. And this shows that only 3.9% use ABPM a majority of the time. Question 6 asked if 24-hour ambulatory blood pressure monitoring was available, and 28.2% said it was. And then you can see that 58.8% said that if 24-hour ambulatory blood pressure monitoring were available, that they would use it to confirm a new diagnosis of hypertension. And this question 8 asked about the greatest perceived barriers to the implementation of ABPM. And those that were listed most often were access to the equipment and the logistics required to implement. In our bivariate analysis, there were few statistically significant findings, but overall, there's no remarkable demographic associations. These results demonstrated that the family physician respondents frequently utilized office-based blood pressures alone for the diagnosis of both essential hypertension and white coat hypertension. However, the best available evidence has highlighted the importance of using ambulatory blood pressure measurements, whether that's home blood pressure logs or 24-hour ABPM, with the latter being the gold standard. This avoids overdiagnosis due to white coat hypertension and misdiagnosis due to masked hypertension. Additionally, 24-hour ambulatory blood pressure has the added value of providing an assessment of nighttime blood pressure. The Hygieia chronotropy trial discovered that bedtime blood pressure dosing of at least one med improved cardiovascular events. These findings confirmed the results of the MAPEC trial. And physiologically, this is thought to be due to the replication of the normal circadian dipping pattern, which is demonstrated here below. The absence of this dipping pattern is a strong prognostic factor for cardiovascular outcomes. It's important to note that 24-hour ABPM is the only method by which one can identify these high-risk patients. And once again, the barriers to implementation of this service included logistical support, access to the equipment, and part of this was the cost, which can range from $1,250 to $1,500 for the device, software, and computer. The limitations to the study include the low response rate as we transition to a virtual medium, which raises a question of possible selection bias, though the demographics suggest a representative sample. This study also had the inherent limitations of a cross-sectional study. So in conclusion, this study found that a significant number of uniformed services family physicians identified office blood pressures as adequate to diagnose hypertension, and clinical practices were found to align with these results. Additionally, while most do not have access to 24-hour ABPM, a majority would utilize it if it were available. In future studies can further evaluate the barriers to implementation of 24-hour ABPM and how to overcome them. And here are references. Thank you all for your time. I look forward to addressing any questions or thoughts that you may have.